The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
So I'm From Western Health in Victoria. For those of you that may know Western Health, we are made up of four sites, so Footscray Hospital, Sunshine Hospital, Williamstown Hospital, and we do have a smaller Sunbury Day Hospital. I'm the Critical Care Outreach Manager there, and I've come to talk to you about whether or not the ICU nurse should be the first primary responder. I'm going to base my talk on Western Health and what we do at Western Health, and we'll just go from there. Western Health has adopted an innovative model to respond to clinical deterioration. We're unique in that we utilise the ICU Liaison Nursing service as our first primary responders for clinical deterioration. These nurses work in collaboration with the home medical teams to support the process of clinical deterioration at Western Health. Just of note, I'm going to mention some benchmarking with some of the other services in Victoria. Some of our other services utilise a MedReg, an ICU registrar as part of their MET team. One other hospital in Melbourne utilises a dedicated 24/7 nurse and medical staff member. So at Western Health, we implemented a revised rapid response system in February 2016. This revised system was based on a three-tier approach. The first level, urgent clinical review, which was a mandated response medical review of the patient. The second tier, MET call, was a mandated medical response, but first of all with the ICU nurse as a first responder, activated by a 444 call through switch and activation of the ICU Liaison Nursing paging system. The third response, Code Blue, unchanged. I'm just going to note here, it was unchanged from our previous system. Western Health prior to 2016 also had an efficient system of managing clinical deterioration, and that was the ICU Liaison Service, which was established in 1998. It was a two-tiered response, and it was a daytime response by the ICU liaison staff via a request from medical and or nursing staff to attend for clinical deterioration, and secondly the Code Blue response. Our Code Blue response at Western Health is not run by our intensive care nurses. It's based by our coronary care nurses, ICU consultant and anaesthetics. In our first year of our revised system, we had 2,833 MET calls, and hypertension was the main reason for a MET response. As part of looking at how to review the effectiveness as the ICU liaison nurse as the first primary responder, we conducted a comprehensive review of our system, and we looked at both quantitative and qualitative methods of data collection. We looked at outcome data from our MET register to have a look at, and see how effective our ICU liaison nursing role and how effective they were as the primary responder. We also conducted staff surveys consisting of open and fixed choice responses to provide objective data and aimed at prompting staff opinion on the rapid response process and the responder roles. I'm just going to go through this quite briefly because I know it's data that everyone here has seen before and it can be quite tedious. We looked at the number of MET calls that were initiated. As you can see here, Footscray and Sunshine are our two main campuses, and Williamstown is a smaller hospital. And this is a total of the 2,833 calls in our first year of our revised system, and we were receiving between 200 to 250 calls a day across the sites. Also looking at, we did a review of our MET calls for time of day as a way to look at how effective our ICU liaison team in particular were effective in managing clinical deterioration, and we found that the majority of MET calls at Western Health across our two main sites occurred between 8 a.m. in the morning and about 9 p.m. at night. And so we have, oh sorry, I'm talking about the wrong slide. Apologies. So we on average have about 4.2 calls in a 24 hours per site. And then I'll go to the next slide. Sorry, I'll mark that one up. So we looked at our locations of where our MET calls were occurring. We found that the top 10 units with the highest MET call represent 60% of all our METs. And 12% of our MET calls were transferred to a higher level of care. And just of note, only 6% of those were transferred to the intensive care unit out of the total 2,833 calls. This is just a demonstration of the effectiveness and the good ward management that our ICU nursing team provides at ward level, helping prevent further deterioration and higher level care requirements. Oops. Sorry. We also had a look at the impact of the ICU Liaison Nurse as the first primary MET responder on our Code Blue outcomes at Western Health. I just wanted to again note that we had a liaison service at Western Health for quite a long time, since 1998, and it was a very efficient system, and it was very effective in identifying and responding and escalating clinical deterioration. The implementation of the revised system in February 2016 has not made a difference to our total number of Code Blues per month. So that's Code Blue calls, not necessarily cardiac arrest data. The cardiac arrest data at Western Health, the median rate fell from 4.67 to 4.25 following the implementation of MET response, although this is not statistically significant. So again, I guess having that ICU liaison service as a very well-established team and being those first primary responders for MET, and they can recognise and escalate clinical deterioration effectively, has helped keep our cardiac arrest numbers quite low. I'd like to thank Dr. Fennessy and Dr. Mulder for helping me provide this graph. It's a mortality following cardiac arrest pre and post our MET our formalised MET information in February 2016. The rate of mortality following cardiac arrest in health was low prior to the implementation of the revised rapid response system, utilising the ICU nurse and the clinical support nurse as the first primary responder. There was no change in frequency from January to December 2015 to January to December 2016, which was about 0.7 per 1,000 admissions. This was above our overall average from 2004 to 2015, which our overall average was 0.57 per 1,000 admissions. There was no difference in the average mortality rates in in-hospital cardiac arrest in the 12 months pre and post the formal MET implementation. Again, however, we've had a very established ICU liaison response and rapid response system since 1998. We also have looked at some qualitative data to see how to rate the overall effectiveness of the ICU nursing team as the first primary responders at Western Health. We conducted staff surveys, which were designed consisting of both open-ended and fixed choice responses to provide objective data on the ICU nurse as the primary responder, and aimed at prompting staff opinion on the rapid response process and the rapid responder roles. The Western Health Rapid Response Survey was conducted from the 19th September to the 17th of October and saw 441 out of a possible 4,633 responses during the survey period. So 9.5% of all clinical staff across all 4 of our sites responded to the survey. The response breakdown was 299 nursing responses and 142 medical responses. So from that survey, the open-ended questions were categorised into 6 themes, and they indicated that the ICU liaison plays a key supportive role in the rapid response process at Western Health, and the majority of staff surveyed indicated the current responders were effective in managing and escalating clinical deterioration in a timely manner. This is just an example of one of the responses that we got out of that survey. Feedback from the staff survey noted the challenges of the after-hours cover, in that the variable demand across the fixed staffing levels was challenging, and the difficulty of ad hoc teams where members do not know each other. This feedback prompted a further review of our MET response and our MET data, and looked at time of day. Data suggested that Western Health, predominantly our calls are between 8 a.m. and 9 p.m, and the current ICU Liaison team's hours are based along this. However, 37% of our MET calls occur out of these ICU Liaison in-hours service. So 37% of our calls at Western Health occur from 9 p.m. to 8 o'clock in the morning. This is similar across both of our major sites, and it's not covered specifically by our ICU Liaison, but rather by our ICU clinical support nurses. So this is a large pool of 129 nursing staff, compared to the 7 nursing staff who cover across the 2 sites in hours. I guess I do need to point out that these large numbers of potential MET responders and the infrequency of infrequency of exposure to MET and the ability to refine their process during MET sometimes can be challenging. No one likes to talk about money, especially when we're talking about the deteriorating patient, so I'm not going to go into this too much, but the cost of our service, utilising the ICU Liaison Nurse, clinical support nurse as the primary responder, is efficient and a cost-neutral way to manage and respond to clinical deterioration. At Western Health, a rapid response service is supported by our ICU Liaison service, which is 7 nurses who work across the 2 major sites. Of those 7 nurses, we have 1 nurse practitioner, and we have 6 ICU nurse consultants, which is a total of 4.79 EFT across 2 sites. Our out-of-hours response is currently covered and supported by our clinical support nurses within the current ICU resource. I'm not going to talk much about this. This is just a chart which just shows some of the different classifications per 1 EFT of cost of nursing in comparison to a possible medical cover. So, in conclusion, at Western Health, the ICU nurse as the first primary responder provides an appropriate level of patient safety and effectively responds and recognises and supports the management of the deteriorating patient. The role of the liaison nurse and the clinical support nurse as the primary responder to MET is seen as a contributing factor to low hospital mortality, low cardiac arrest rates and few cases of unrecognised deterioration prior to cardiac arrest at Western Health. Thank you.